Okay, we could get started. This morning, during the first hour, I'll be talking to you about how blood flow to the heart and the brain are regulated or controlled. And then in the second hour, we'll be talking about the control of blood pressure. So the objectives for the first hour are really to understand what the mechanisms are as far as they are understood for the regulation of coronary and cerebral blood flow, to explain then, once we understand these mechanisms, how we can preferentially distribute the cardiac output to the heart and the brain under conditions where there's a reduction, for instance, in blood pressure. And then we'll talk about some specific things like the Cushing reaction. I have to start out with an apology for you. Unfortunately, the slide presentation that was uploaded for you for this has some duplicate slides, so you're not missing anything, but there will be some duplicate slides in there that I will be skipping over. Yes? They're not on. Okay, so that won't be a problem since you won't be able to see them. Thank you. So as I was explaining, and again, it's I wish I could blame somebody else, but it's my fault since I uploaded it, that there will be some duplicate slides. Just skip over them if you're not on the slide that I'm on once we eventually get the projector working. And hopefully that should show up. Good. Okay, so what we're really talking about is sort of a theme in physiology, and that is the maintenance of homeostasis, keeping a constant environment for the tissue. And the maintenance of homeostasis is critically important for both the heart and the brain, because again, we said that these are two tissues whose depolarization really controls their function, and these are two tissues that can't tolerate ischemia for any prolonged period of time. There's not a lot of energy stores in either of these tissues, so it's critically important for our survival that we really, under all conditions possible, try and maintain blood flow to the heart and the brain. And therefore, when we think about the mechanisms responsible for controlling flow to these two tissues, we'll see that they're really a priority. We are designed to keep blood flow maintenance to the heart and the brain as a priority. And again, I just go back to this kind of diagrammatic illustration I've given you previously just to remind you of the fact that the heart and the brain are connected to all the other organs with reference to blood flow distribution by parallel circuits. And therefore, it's the change in the relative resistance in either the heart or the brain, and then the relative resistance in other organs of the body that will have an influence on what fraction of the cardiac output goes to those organs. So the way that we're controlling flow there is to control vascular resistance locally, because the pressure gradient across all of these organs is essentially the same. I also had shown you previously that when we look at the myocardium, there's a much, much larger density of capillaries within the myocardium than there is in other tissues of the body. And the one thing that's kind of strange on the surface is that we talked about the fact that in other organs, you can increase oxygen delivery to a tissue by increasing the number of capillaries perfused. Remember that sitting here, you don't normally perfuse all the capillaries in your body. You normally perfuse only a fraction of the capillaries. And in a tissue that's not getting enough oxygen, in many areas of the body, we can just increase the number of capillaries perfused and get more oxygen extraction. That mechanism is not available for the heart. And the reason it's not available for the heart is that under basal conditions, we're pretty much perfusing almost all of the capillaries. So the heart cannot use increased extraction as a means to get more oxygen to the myocytes. So it becomes almost what's called a law of the heart, that if we have to increase oxygen delivery, either because of an increase in metabolic demand or a decrease in perfusion pressure, what we have to do is to dilate the coronary resistance vessels and increase flow. Increased demand for oxygen has to be met by an increase in coronary blood flow if the heart is going to continue to function normally. Now, in Gross, you, I'm sure, studied the anatomy of the heart, and you studied the major blood vessels supplying the heart. So you know that the supply to the heart comes from the right and left coronaries, which have their ostia or origin really in the root of the aorta, and that the left coronary sort of divides into the circumflex and the left anterior descending, and the LAD is really supplying a major portion of the ventricle. So you know about the arterial supply, but what you might have not thought about is that all of those arterioles run along the surface, those arterial vessels run along the surface of the heart. And what it means is that in order to supply the ventricle, the wall of the ventricle, the arterial blood vessels have to dive down into the wall itself. So they have to be interspersed between the contracting myocytes. And why is that important? Well, it's important because with each contraction of the ventricle, those myocytes are compressing those blood vessels. So if you picture like my right hand, the fingers of my right hand being the blood vessels that supply the heart, and the fingers on my left hand being myocytes, we have the fingers of my right hand going in between the myocytes, and every time the heart contracts, it's squeezing those blood vessels, which means that we're actually increasing resistance to blood flow because we're narrowing the vessels. And what this also illustrates is that during systole, when we have the ventricle contracting, we actually squeeze the blood vessels on the endocardial side, that's the side lining the lumen of the ventricle, more than we squeeze the vessels on the epicardial side. Again, it would be like if we had a group hug at the bottom of the room. Those people in the middle would be squeezed a lot, whereas those people on the outside would be doing the squeezing. So the vessels on the endocardial side get squeezed a lot more during systole than the epicardial vessels. Therefore, their flow is reduced more during systole on the endocardial side than it is on the epicardial side. However, if you measure blood flow distribution across the wall of the ventricle over many heartbeats, what you find is that the endo to epi ratio, the ratio of blood flow to the endocardium versus the epicardium, is the same. Actually, the endocardium actually gets even a little bit more flow, but it's just about the same. So how does that happen? Well, the way that that happens is, of course, if the endocardium is getting less blood flow during systole, it must be getting more blood flow during diastole. And the reason that it gets more blood flow during diastole is that during diastole, the endocardial vessels are more dilated than the epicardial vessels. So they're closer to their maximal diameter. And why is that important? Well, the reason that's important is, remember when we talked about autoregulatory reserve? And if there's a decrease in the perfusion of a tissue, the way that the tissue can compensate for that is to vasodilate, lower resistance, and maintain blood flow even with that reduced perfusion pressure. Because the endocardial vessels are more dilated in order to increase this diastolic flow and equalize flow across the wall of the ventricle, it means they're closer to their maximal diameter. So actually they have less autoregulatory reserve. If there's a drop in blood pressure, or if there's occlusion of one of the major coronary vessels, the endocardial vessels are already pretty close to their maximum diameter, whereas the epicardial vessels can dilate much more. So it means that the endocardial side of the ventricular wall is much more susceptible to ischemia. And indeed, what we find is that with reductions in blood pressure or occlusion of a major artery, infarcts tend to form first on the endocardial side. However, I do want to emphasize that normally there's an equal distribution of blood flow throughout the ventricular wall. There's another sort of consequence of this tissue pressure that we can actually see when we look at total coronary flow. And I'll go through this. This is kind of a common board type question. What we have illustrated here are essentially three things: the aortic pressure curve, blood flow measured through the left coronary artery, and blood flow measured through the right coronary artery. What happens is pretty much dictated by the same physical principles on the left side and the right side, but the effects are much more dramatic on the left side because the left ventricle generates far more pressure. Okay? So what we're looking at here is what happens to coronary blood flow during one heart cycle. And what you see is that there's a dramatic reduction in coronary blood flow during isovolumic contraction. It actually may even reverse. And that the highest flow actually occurs during isovolumic relaxation. And we can use a rearrangement of Poiseuille's law to explain why we get these cyclical changes in coronary blood flow through the left coronary. So remember that the amount of blood flow that's going to go through this coronary is determined by the ratio of the perfusion pressure to the resistance that the vessels offer. And what we're saying is we'll get the highest flow when this ratio is largest, and we'll get the lowest flow, obviously, when the ratio is smallest. So what's happening during diastole? All during diastole, aortic pressure is decreasing. This perfusion pressure, we said that the origin of the large coronaries is in the root of the aorta. So this pressure gradient, this perfusion pressure, is really determined by primarily aortic pressure. The right atrial pressure doesn't change nearly as much. So all during diastole, delta P is decreasing. When we start isovolumic contraction, not only does delta P continue to decrease because aortic pressure continues to decline, but also now we start to significantly increase resistance to blood flow because the ventricle is compressing the vessels. So we have a combination of a very low perfusion pressure and a high resistance, and that causes blood flow to actually stop or reverse. Then at the end of isovolumic contraction, when we start to eject into the aorta, perfusion pressure starts to increase. So with that increase in perfusion pressure, even though resistance is high, we start to get an appreciable flow. And it continues to increase in parallel with the aortic pressure curve until we reach the peak of aortic pressure. So now we're still having a high resistance. We have the peak of aortic pressure. And now what happens is the aortic pressure starts to decrease again during the slow ejection phase. So flow starts to decrease. But now we get isovolumic relaxation. And what's happening during isovolumic relaxation? We no longer have the ventricle squeezing the blood vessels, so now the resistance becomes much lower. We're lowering the resistance, and also perfusion pressure is still pretty high. It's not the peak aortic pressure, but it's still fairly high. And as a result of the fact that we have this high perfusion pressure and low resistance because the ventricle is no longer contracting, you get maximal flow through the left coronary during isovolumic relaxation. And of course, this repeats with every heart cycle. So it's really just understanding Poiseuille's law and how these factors change with the cardiac cycle and how aortic pressure changes that gives us an explanation for these rather dramatic alterations in left coronary flow. And again, in principle, the same thing happens on the right side, but since the right side is developing a lot less pressure, we don't get as dramatic a change. So if we talk about the influence of autonomic nerves on coronary blood flow, we said that the sympathetic nervous system is the primary factor in controlling total peripheral resistance. And the heart blood vessels are actually innervated by the sympathetic nerves and the parasympathetic nerves. What I have for you here on the slide is the bottom line. And the bottom line is stimulation of sympathetic nerves innervating the heart increases coronary blood flow. Again, in other organs like skeletal muscle, skin, the gut, if we stimulate the sympathetic nerves, we cause a decrease in blood flow because it makes the blood vessels constrict. The reason that the situation is opposite in the myocardium is, again, the control of resistance in the myocardium is dictated primarily by local control mechanisms, by metabolic and myogenic control mechanisms. And what happens is that when you stimulate the sympathetic nerves, we increase the metabolic rate of the heart because the heart beats with more contractility and it beats more rapidly. So because the metabolic demand goes up, that's what causes the increase in blood flow. In actuality, there are alpha receptors, especially in the larger coronary vessels, that if you didn't change the heart rate and you didn't change contractility, blood flow would actually go down. So the direct effect of the sympathetic nerves is to constrict the vessels. But that effect is overridden by local metabolic and myogenic control mechanisms. And the net result is that, especially with metabolic control mechanisms, stimulating the sympathetics actually causes an increase in coronary flow. And the opposite is true with parasympathetic nerves. When you stimulate the vagus nerve, which is the parasympathetic nerve innervating the heart, it lowers the heart rate. And with that lowering of heart rate, there's a decrease in metabolic demand. And with that decrease in metabolic demand, there's a decrease in coronary blood flow. So again, we see that we have this circuit that's arranged in parallel with other circuits, but is responding very differently to autonomic activation, to sympathetic stimulation. And this is exactly what we'd want to do, because let's say we've hemorrhaged and our blood pressure decreases. What we wouldn't want to do is to increase vascular resistance in the heart and the brain. We want to increase it elsewhere so we can deliver a greater fraction of whatever cardiac output is left to the heart and to the brain. So this is the bottom line of what happens. We used to think we understood very well the metabolic control mechanisms that were responsible for regulating coronary blood flow, and there was actually something called the adenosine hypothesis that was almost axiomatic for many, many years, and everyone thought that it was adenosine that was really responsible for the regulation of coronary blood flow. Now we know that adenosine does play a role. Now remember, the energy store is adenosine triphosphate, and if we have an increase in metabolism or a decrease in oxygen supply, we break down adenosine triphosphate into diphosphate, monophosphate, and adenosine. That adenosine diffuses out and interacts with adenosine receptors on the blood vessels and causes them to dilate. That does operate within the heart. But it seems that there are other factors that are also contributing to the regulation of coronary blood flow. And since it's not especially well understood, I think we'll just leave it at the level that there is very, very potent metabolic control over vascular resistance in the heart. We have a very close coupling between the resistance to blood flow and the metabolic rate of the tissue through the metabolic control mechanisms we talked about previously, and it's not totally clear exactly which metabolites are contributing. We do know that adenosine is one, changes in oxygen tension may be another one, but there is this very, very sort of important metabolic control of coronary blood flow. All right, so we've talked about neuronal control and metabolic control. We can also talk about the development of collateral vessels. Remember when we talked about this network formation in which we have arterial anastomoses, and arterial anastomoses are direct connections between arterial vessels that provide an alternative channel. So we have a number of these arterial anastomoses within the heart, and those are what are referred to as collateral vessels. And the idea is that if we have an embolus or an atherosclerotic plaque that's occluding a major coronary vessel, we can utilize that network pattern. We can utilize those collaterals to try and perfuse areas that would normally become ischemic if these were all end arterial vessels. So the collaterals provide some protection against occlusion of the major coronary vessels. However, they're usually pretty small. So if the occlusion occurs very rapidly over a short period of time, they're really inadequate to provide a lot of protection for the myocardium against ischemia. If the occlusion occurs over a long period of time so that we have a slowly developing atherosclerotic plaque, there's time for these collaterals to actually increase their diameter. And on angiograms, you can see really large collateral vessels, so they actually do protect the myocardium. So I guess the major message that I'm trying to give to you is that the effectiveness of collateral vessels in compensating for reductions in blood flow through a major coronary depends upon how rapidly that reduction occurs. And of course, there's a lot of research directed at trying to understand how we could improve that collateral circulation. So that's pretty much the story for regulation of blood flow to the heart. What we'll do then is to move on and talk about regulation of blood flow to the brain. And again, the major thing that I want to emphasize in talking about both of these organs is the priority that we give to local control mechanisms compared to other tissues. So someone had suggested we put thought questions in. I think that's a good idea. And this is a thought question that, surprisingly to me, I've heard sort of fourth-year medical students and residents sometimes have misconceptions. And the question is, how does the regulation of cerebral blood flow differ from the regulation of blood flow to other organs? And A, it's directly proportional to the cardiac output, and B, the pressure gradient across the cerebral vessels is different than the gradient across other organs, or both are true or neither is true. If you think about it, neither is true. And a mistake that sometimes people make is to think when there's a change in cardiac output, if it increases or decreases, automatically there's the same degree of change in blood flow to the brain. And that's not true. Again, what we get is this local autoregulation that compensates, hopefully, for those changes in perfusion pressure, that tries to maintain normal blood flow to both the heart and the brain. And, the gradient is the same across all of these organs. The difference is that the brain and the heart are less responsive normally to sympathetic stimulation than the other organs, which again allows us to redistribute that cardiac output to those vital organs that are very intolerant of ischemia. So I guess I've hammered that enough. You've studied the major vessels supplying the brain in Gross. So we know that the brain is really supplied by 4 vessels, 2 vertebrals and 2 carotid arteries, okay? And for those of us who are fortunate, they form one of those network patterns, the circle of Willis, that again helps to provide for adequate circulation if we do have occlusion of one of the major vessels, again, if we're fortunate enough to have a patent circle of Willis. And of course, the 2 vertebral arteries join together to form the basilar artery. So that's not news to you. What you might have not thought about is the fact that the large cerebral vessels actually contribute more to resistance than large vessels in other organs. So the large cerebral vessels, because they're so long, actually contribute a significant amount of resistance to blood flow. And because of that, we'll talk about later, the effect of sympathetic stimulation is actually a little different in the brain than it is within the heart. But the idea is that if we cause changes in the diameter of the large cerebral vessels, that can have much more influence on the magnitude of blood flow perfusing the brain than blood flow in other organs, or large vessels in other organs. To be really honest with you, much of what we understand about the mechanisms responsible for control of cerebral blood flow are still a mystery. We really don't understand totally how cerebral blood flow is controlled. I can start with some older concepts that are still important and still valid. One of the ideas is that changes in vascular resistance in blood vessels supplying the brain are very closely coupled to changes in blood carbon dioxide content. So if CO2 goes up, we get dramatic increases in cerebral blood flow. So this shows the situation where we have normal control of CO2, and remember we have this autoregulatory curve in the brain where we can maintain constant blood flow over a wide range of perfusion pressures. However, if the amount of carbon dioxide increases in the blood, if our respiration decreases, for instance, that would cause an increase in CO2, we get a dramatic increase in the amount of flow that we have perfusing the brain. So there's exquisite sensitivity of the cerebral vessels to CO2. The neurosurgeons use this, okay? They tell me that the worst thing that they can see is when they do a craniotomy and the brain starts to swell and the brain starts to herniate up through the cranium. And that's, of course, due to swelling and an increase in pressure within the capillaries and forcing more fluid out. So what they do under that circumstance is immediately tell the anesthesiologist to turn up the respirator. And by turning up the respirator, the patient blows off CO2, blood CO2 content goes down, and that causes constriction of the cerebral vessels. So that's just an example of this close coupling between blood CO2 and the resistance to blood flow within the brain. Despite that, it seems that changes in local CO2 are not one of the primary mechanisms controlling cerebral blood flow. We'll talk about that a little bit more. Overall, the cerebral blood flow doesn't change very much under normal circumstances, so it remains at about 60 mils per minute per 100 grams of tissue. This is really an old experiment that was done with radioactive tracers, but I still think it's fascinating. What they did is to add a radioactive tracer to the blood, and by putting a scanner then over the cranium, they were able to track changes in blood flow. And what's fascinating in the brain is immediately when there's a change in the activity of one of the areas of the brain, there's immediately a change in blood flow to that area, matching the new metabolic needs of that tissue. And it happens in a second. So if you tell somebody to just periodically open and close their hand, you see a dramatic increase in blood flow to the motor cortex and the premotor cortex, all the areas that are involved in that activity. Areas involved in reading or problem solving, we can redistribute the blood flow to those areas. So what it tells us is there's this exquisite coupling between tissue need and the amount of blood flow that goes to the region of the brain. Even though overall cerebral blood flow doesn't change, we redistribute within the brain blood flow in order to match the activity of the tissue. We've already talked about autoregulation in the brain, and we talked about acute autoregulation and long-term or chronic autoregulation. And remember, we talked about how people who are sort of subjected to a prolonged exposure to increases in blood pressure will shift their autoregulatory curve to a much higher pressure range. So we have metabolic and myogenic control mechanisms that are contributing to this short-term autoregulation, and then again changes in morphology of the blood vessels within the brain that will contribute to this long-term autoregulation. And then the next slide is one of those that you should skip over if that's on your computer and that's what you're looking at. The next thing I want to talk about is actually tissue pressure does have an influence on blood flow to the brain. And this reaction called the Cushing reaction actually demonstrates again the priority that the brain has with regard to distribution of the cardiac output. So what the Cushing reaction is a response to an increase in intracranial pressure. Our craniums are rigid structures. Some people more rigid than others. But the cranium is rigid and it's non-distensible. So what that means is that if one of the intracranial contents increases in size, something else has to be shrunken or decreased in size. And what happens is if there's an increase in intracranial pressure due to a subarachnoid hemorrhage or a rapidly growing tumor or increase in filtration, we get this response called the Cushing reaction, which in response to the increase in intracranial pressure, there's a dramatic increase in total peripheral resistance and an increase in mean blood pressure. So what's happening is if intracranial pressure goes up, we start to squeeze the veins and we squeeze the blood vessels and cerebral blood flow goes down. And because it's so threatening in response to that, the brain uses the rest of the circulation to try and perfuse itself. So it causes an increase, a dramatic increase in blood pressure, and blood pressure can come to very high levels. The weird thing about the Cushing reaction is one would think that in addition to this increase in total peripheral resistance and increase in mean blood pressure, we'd also be seeing an increase in heart rate. But in reality, with the Cushing reaction, there's a bradycardia. There's a decrease in heart rate. And the only way that this makes sense to me, we'll talk in the next hour about the control of blood pressure, but we actually have sensors in our arterial vessels that tell the brain what blood pressure is, and those are connected to the parasympathetic nerves innervating the heart. So bottom line, I think because of the way that we're hardwired, what happens is when we do get this Cushing reaction causing an increase in the sort of resistance to blood flow because of increased intracranial pressure, we increase systemic arterial pressure, but as a leftover for the way we normally control blood pressure, the parasympathetic nerves innervating the SA node become more active, and we end up with a bradycardia. So diagnostically, this is important also. If you you have a patient come into the emergency room with head trauma, and especially if they have a fovea that's kind of pushing out and very high blood pressure, if that's associated with a bradycardia, you're suspecting that there's a significant increase in intracranial pressure. We can talk next about neuronal control of cerebral vessels. And if this slide is a little busy and confusing, so is what we know about neuronal control of cerebral vessels. It's not totally understood. So it turns out that the cerebral resistance vessels are innervated by sympathetic nerves. They're innervated by parasympathetic nerves. They're also innervated by sensory nerves. And finally, there are intrinsic nerves that also contribute to their innervation. And the bottom line is that we don't have a great understanding of how this works. And one of the things that people speculate about is that these intrinsic nerves maybe contribute to the rapidity with which the cerebral vascular resistance changes in response to an increase in activity. Again, what I want to emphasize is in other tissues where we do have coupling with local activity, that takes minutes to occur. In the brain, it happens actually within a second. It turns out that if you start to have activity in one area of the brain, before the metabolism goes up and oxygen decreases, we actually get an increase in oxygen delivery, really almost in anticipation of that. So the major question is how this can occur. And one of the reasons that people think this might occur is with these intrinsic nerves that may be sending messages for dilation of the vessels. When we think of the sympathetic nerves, we get kind of a strange phenomenon that occurs with sympathetic stimulation. And again, sort of the question here, how would the fact that larger vessels, macrovessels, contribute more to vascular resistance in the brain than in other organs? It really explains a phenomenon that we don't see in other areas. So again, let me give you the bottom line here. And the bottom line is that if you have a reduction in blood pressure, if we become hypotensive, when we become hypotensive and stimulate the sympathetic nervous system, that does not cause an increase in cerebral vascular resistance. So even with sympathetic stimulation, we don't change what happens at the low end of the pressure curve. However, what does happen is under conditions of hypertension, when blood pressure goes up, stimulation of the sympathetic nerves actually causes an increase in cerebral vascular resistance. So if you want to think about this teleologically, why would it be good to have it arranged like this? What happens is if we're hypotensive, if we have a reduction in blood pressure, again, we don't want to increase cerebral vascular resistance. We want to get a lot of blood flow to the brain. So it's good that the cerebral vessels don't respond to this sympathetic stimulation. On the other side, if somebody is sort of acutely excited, somebody rear-ends you as you're driving down Broad Street, and your blood pressure becomes really elevated, it's actually protective for the brain to have the cerebral vessels increase their resistance and protect the capillaries from the transmission of that high systemic pressure to the capillaries. So what happens here is we actually get this shift in the autoregulatory curve on the high pressure side during sympathetic stimulation, where we don't influence it on the low pressure side. So bottom line for you, in response to hypotension, sympathetic stimulation does not increase cerebral vascular resistance, but it does increase it when blood pressure goes up. The parasympathetic nerves don't seem to normally influence regulation of blood flow to the brain. What may happen is they may influence, it seems, with some experimental animals, the development of collateral flow. And again, these sensory nerves, which actually secrete substance P and CGRP, these nerves that are sensory nerves actually secrete vasodilators and are associated with pain and may have an influence on migraine. So you'll study that a little bit later. They also oppose very intensive vasoconstriction. If we think about the brain, we also have to sort of give consideration to sort of a new way to look at the brain, at least different from the way that I was taught. And I think this is also an extremely important concept for you. And that is, we can't think about just function of neurons. We really have to think about something called the neurovascular unit. And the more that we understand how the brain functions, the more we understand the importance of communication among all of the cell types contained within the brain. So what this means is that contained within the brain, we not only have neurons, but we have blood vessels, capillaries with pericytes. We have glial cells. The microglia are really the resident inflammatory cells within the brain. We also have astrocytes, and as we'll see in a minute, these astrocytes are critically important in controlling cerebral blood flow. It turns out, we think now, that microglia may be critically important in controlling dendritic spines on neurons, so therefore may control neuronal communication. And the astrocytes are critically important in controlling synaptic plasticity and synaptic strength. So bottom line, when you think about what's going on in the brain, and as you learn about this in the future, what you'll learn is that all these cells talk to each other. They're constantly sending signals, cytokines, other chemical signals, and they're all in communication. And in reality, the activity in any of one of these cells can influence the activity of all the other cells. So as we analyze what's going on, we really have to think about really a neurovascular unit and not just think about changes in action potentials in neurons and synaptic transmission. It's much, much more complicated than that. Another difference in the brain that we mentioned previously is this presence of what we call the blood-brain barrier. So it was to me, it was an interesting historic phenomenon. There was a guy named Ehrlich who was a very, very famous neurobiologist. And he did a study in which he injected Evans blue, a blue dye, into, I think it was rats, into an animal. And what he found is the whole animal turned blue except for the brain. And so his interpretation is that neuronal tissue does not take up this Evans blue, this dye. Well, he had a graduate student that had an interesting idea. He actually dropped the Evans blue on the brain and found that the brain very aggressively takes up this Evans blue. And out of those experiments, we came with the idea that the permeability of material across the brain endothelial cells is very much more restricted than it is in other areas. So there's the presence of a blood-brain barrier. If you measure electrical resistance, the impedance is about 40 times higher within the brain. The primary location of the blood-brain barrier, which is really going to control how easily material can move from the lumen of the blood vessels into the interstitium, the primary location for that control is at the level of the endothelial cells. And the difference in the brain is the presence of these adhesion molecules called occludins, and also a molecule called claudin 5, which are much more sort of prevalent in cerebral endothelial cells than they are in other areas. The idea is that there are adhesion molecules between the endothelial cells, and these tightly joined adhesion molecules are responsible for this blood-brain barrier. Now, what's also true is the development of the blood-brain barrier is controlled to a large degree by astrocytes. About 90% of the blood vessels within the brain are surrounded by astrocytes. And the astrocytes are very important in developing this phenotype of endothelial cell that creates the blood-brain barrier. Microglia also have an influence, and parasites have an influence on this blood-brain barrier. This slide illustrates the fact that we not only have these junctional adhesion molecules between the endothelial cells, but there are actually accessory molecules within the cytosol of the endothelial cell that are connected to the actin cytoskeleton. Bottom line, when the endothelial cells become activated or we get interaction between a leukocyte and an endothelial cell, we can get signaling that occurs that causes phosphorylation of these adhesion molecules that can weaken the junction. And this is, of course, what allows cells to move in between the endothelial cells and get within the brain. So the only thing that I'm trying to get across to you is that we have this very, very restricted transport, but that it can be modified by changes in endothelial cell function. This blood-brain barrier will become very important to you as physicians because it will determine which drugs you're going to use. A number of drugs, again, you can use systemically that won't cross the blood-brain barrier. That can be advantageous. You may want to modify the blood-brain barrier in order to get material to move across. Or you may, use drugs that cross very easily. So it's something you're going to have to learn about when you get into pharmacology about how readily drugs move across the blood-brain barrier. This slide just shows various pathways that are available. Again, this water-soluble pathway is very, very restricted. The one thing I wanted you to see is that there is vesicular transport. There's a lot of mitochondria in cerebral endothelial cells, and because of that, we have a lot of active transport. So because material can't diffuse very easily, we have active transporters for things like glucose and amino acids and other material that we have to get into the brain. And there are also exclusion pumps. So there are actually pumps on the endothelial cell membrane. They have polarity. So in some cases, they're abluminal on the opposite side of the lumen, and in some cases, they're luminal. But we have pumps that can also transport material from the brain back into the lumen of the blood vessels. And those pumps also have an effect on sort of the influence of various pharmacologic strategies. So we just see that we have a number of pathways that is available, but again, the movement of material across these cerebral endothelial cells is very restricted. Within the cerebral capillaries, we have cells that surround them called pericytes. And the density of the pericytes is much, much larger in the brain than it is in other areas of the body. And these pericytes are very important. This first slide just illustrates that there are actually gap junctions. So very often there are regions in which there's no basement membrane between the endothelial cell and the pericyte, and there are direct connections between endothelial cells and pericytes through these CX43 gap junctions. The whole importance of this is there's an intricate communication between the parasites and the endothelial cells. And really, parasites control sort of angiogenesis, and they can either activate angiogenesis by turning on the endothelial cells to replicate, or they can inhibit angiogenesis. So we have a lot of control of what the endothelium is doing through the parasites. They are very important in angiogenesis and vasculogenesis, so the development of blood vessels. And again, with these slides, I do not want you to learn the details of what's on here. I just want to get you to the bottom message of how intricate and complicated the communication is between the parasites and the endothelium. So we can have parasites causing the endothelial cells to detach. We can have them cause the endothelial cells to stay intact. The most important thing is this slide, which shows various functions of these parasites. And what we see is that the parasites are important in regulating how tight the junctions are and forming the blood-brain barrier. A new idea that's coming across is that they also may become very contractile under conditions of ischemia and may prevent reperfusion of the brain following ischemia, because what happens is the calcium inside these parasites increases when they become ischemic, and they essentially occlude the capillaries. So it will have an influence on stroke, on ischemia, and can also influence all the other functions that I have illustrated here. So again, don't worry about the details in the other slides. If you're going to look at anything, look at this slide and be aware of the various functions that the parasites can have. And what I'd like to do now is just skip right to astrocytes. And again, this returns to this idea that astrocytes are critically important in controlling synaptic strength, because they actually can take up glutamate. And it seems that they control the amount of glutamate that's present in the extracellular fluid and present at the synapse. And you'll learn later, for instance, addiction. Very often addiction is very much related to the amount of glutamate that's released, or whether glutamate uptake, cocaine prevents the uptake of glutamate, okay? Control of this is very important for neuronal function, but the other thing that the astrocytes do is to actually sort of read what's going on at the synapse. The fact that glutamate can interact with metabotropic glutamate receptors on the astrocytes and cause an increase in calcium and cause astrocytes to produce materials that can either cause blood vessels to constrict or to dilate. And I've given you a lot of slides here that show all the mechanisms through which this can occur. Really, what I want you to focus on is just the idea that astrocytes are very active in signaling blood vessels, signaling vascular resistance. They may be part of the explanation for why we can get such rapid control of vascular diameter when there's a change in activity of the neurons. And the fact that the astrocytes can secrete either vasoconstrictors or vasodilators depending on the circumstance. Next year when I talk to you, I think in block 10, we'll talk in more detail about how this can occur and how oxygen can influence it. But we can stop at this point and then really restrict our thoughts to just the fact that the astrocytes are important in vascular control. So in summary, we won't even deal with that. We'll talk about 4 major sort of conceptual changes that are really becoming a new idea in the way that cerebral blood flow is controlled. First of all, that neurotransmitters, especially glutamate, rather than just energy, are used as principal agents in generating activity-induced flow. In other words, they can do this forward control of blood flow even before the metabolic demand of the tissue goes up. They play a major role in blood flow regulation. Oxygen concentration may regulate the relative influences that actually changes in oxygen may dictate whether the astrocytes cause constriction or dilation. So we have a coupling with the amount of oxygen that will be available to the tissue. And finally, parasites. The activity of parasites is becoming, again, a more important area of interest in understanding how we can get changes in the control of cerebral vascular resistance. So on those slides, there's a lot of complex things. Don't get bogged down in that. Really concentrate on the major sort of concepts that I've tried to give you. I'm not going to ask you about the specific metabolites that are released from the astrocytes or anything like that. Okay? Let's take a break, and then we'll come back in the next hour and talk about control of blood pressure.